recovery, and so I've just jumped in to help facilitate. Lucky for y'all, there's not a whole lot that you need me to facilitate because we're going to spend our time, and when I say our time, I mean our whole time talking about these action plans that everybody's been working so hard on. So I'm grateful to be able to dig into that space with you today. Just a quick note for those of you that are hopping on, you might have missed that notification that we get that we are being recorded and streamed and all those things. So that is happening as we speak. So thanks for giving us a little bit of time to bump our meeting 1 week so that we could go through all of these action plans. Um, we want to make sure we get through all of them so that we can get them delivered to the governor by January 31st. And we're in the home stretch. So thank you for hanging in there. I mean, the dedication and the hard work of all the council, the different subcommittees, our support team, it's just been amazing. And thank you all for making this possible. And today we're going to go through the next round of presentations and action plans that have been advanced from the subcommittees. So that means Eli, Julie, and I will be sharing some things, and we've got some other folks that are jumping in to help share action plans as well. So just to keep a heads up, there are 7 plans we're going to go through. So we're going to move through them pretty briskly. If you have thoughts when we get to the end of each of the action plans, please jump in because I'm going to try to keep us moving through things in a pretty timely fashion. So just giving that heads up as we go. So I don't want to take any more time. I really want to make sure that we've got space to go through all the action plans. And Taylor, I don't know, did you get a chance to drop the agenda into the chat just so people know what we're doing and where we're going?
Yes, we do not have a chat function, so I'm happy to quickly
Oh,
walk through if that works for you. Robin,
yeah,
I'll share
let's do that.
screen. Great. Share screen quickly on the agenda. So for today, if folks are able to see this, as Robin mentioned, starting with the licensing and credentialing action plan. So it'll be streamlining and then supporting lived experience in the workplace. And then we'll move to 2 action plans from the recruitment and retention subcommittee, administrative burden and compensation. There's time for a 5-minute break. And then we'll go to 3 plans from the education and training subcommittee, enhancing partnerships and collaboration, expanding degree pathways, and completion and community college collaboration. So there's about 15 minutes per plan, 10 minutes of presentation, 5 minutes for discussion. And I'll turn it back over to you, Robin.
Look we're like a finely oiled machine. It's happening here. Okay, so I think we're ready to start off on our first action plan from licensing and credentialing. Yes? Do we have our person?
We do. And Casey, if you are talking, you are muted.
Sorry about that. I had one more
Ah,
person to direct from the Teams to the Zoom, and now I am fully here.
there you are. I know. I was like, wait a minute. Thanks, Casey. I'm going to turn over to you.
Absolutely. So thank you, everyone. We've got 2 action plans to get through from our subcommittee today. I'm going to try to get through them as quickly as possible to leave as much time for discussion as possible. So go ahead to the next slide, Chad. So our first action plan revolves around supporting lived experience in the workforce. Originally, this was going to be 2 different action plans involving sort of peer credentialing on the one hand, and then issues with background checks on the other hand. But as we had those conversations, they sort of seemed to intermingle to the point that we decided to combine them into 2 different action plans, or into 1 action plan, apologies. So we want to, through this action plan, recognize the central importance of lived experience in behavioral health work. I mean, I think that's something that we've been hearing in conversations all over the place, that as central as peers have always been to sort of the support for behavioral health, it is only becoming more so sort of as the field continues to develop. And we want to make sure that those are people we are encouraging, uplifting, and giving sort of as clear paths into the profession as possible for people who have lived experience of mental illness, substance use, and criminal justice involvement. So sort of the 2 prongs of this, we want to streamline credentialing for certified recovery mentors and traditional health workers to eliminate duplicative requirements and clarify career pathways for peers with lived experience in either or both fields. For those who sort of don't know, Certified recovery mentors are certified by MACBO. Those are peers with lived experience with substance use. Traditional health workers are certified by OHA, and that is a group of different kinds of practitioners, including peers who have lived experience with mental health. One of the issues that we are seeing is that there are a lot of people who have lived experience on both sides of the field, want to be able to apply their lived experience on both sides of the field and be able to treat people who are also grappling with combinations of substance use and mental illness. But we are seeing that there are duplicative trainings where a person basically has to do all of the basic how to be a peer stuff, and then also the specific SUD stuff. And then if they also want to become a mental health peer, they have to do all the basic like how to be a peer stuff all over again. So we're recommending MacBo has sort of already put forth the idea of streamlining some of their peer credentialing, replacing some of it with certifications or sort of micro credentials, so that instead of having to repeat trainings, people can sort of do additional trainings that help them to specialize in the specific field of support that they are doing. And then also having OHA and MacBo work together in order to sort of figure out between the Certified Recovery Mentor program and the traditional health worker program how we can support sort of the new normal that we are moving towards, where there's a lot more overlap in the people who are getting both of those kinds of credentials and the kind of treatment and support that they're doing. And then the other prong of that is we wanted to look at background checks for behavioral health professionals. We want to eliminate unnecessary barriers and reduce disparities and make it easier to navigate the background check process. And this is something that we've had people both inside the Talent Council and in conversations outside of the Talent Council have raised sort of the importance of this, that, you know, the people who are coming into this with lived experience often have the most vital skills for doing this. And at the same time, that lived experience can mean that they have on paper some kind of record that makes it more difficult for them to get through the background check process. And so we both want to be looking at, are we excluding people we shouldn't be excluding? There are a lot of sort of blanket exclusions that, as we talked about them in the subcommittee, did not necessarily make sense. And also, are we helping people navigate the process who potentially are going to need to be submitting, you know, materials for an appeal to a background check, or sort of putting together a portfolio so that the background check people can understand sort of the context around whatever their background is. We had sort of discussed whether we wanted the uh, council to be sort of making direct recommendations regarding what the background check changes should be. But where we landed is that needs to be sort of a longer conversation with more people at the table. And so what we're recommending is the Alcohol and Drug Policy Commission pull together a committee in order to address this and look at sort of those requirements and how they might need to be changed. Next slide, Chad. So I already went through a lot of this on that first slide, but in terms of what we're looking to accomplish, we want to have the new peer credentialing model and the work between MACWA and OHA to basically make it so that people who are becoming peers can get there through the straightest line possible, not having to sort of go back or repeat themselves in order to get the same credentials. We also want to look at those revisions to the background check system. Specifically, one of the things that came up during that conversation is how difficult this has become. And again, this sort of aligns with the peer credentialing issue as well, for providers who are treating both substance use disorder and mental health, mental illness, because there are two separate background check systems for that. And that is for some reasons that are necessary and good. But ultimately, we have not really reckoned with the fact that with the difficulties that that places on providers, the difficulties that places on people seeking to get licensed. And we really need to, I think it's time for us to take a longer look at the background check system and try to create something specific to integrated co-occurring disorders rather than trying to just piece it together from sort of the existing systems. And then finally, creating some support for people with lived experience in navigating the background check process, including potentially sort of like example sort of an example portfolio for people who might need to be submitting additional information, and a guide for being able to sort of like navigate the process in terms of what you submit initially, what you potentially need to submit if you decide to appeal, things like that. Next slide, Chad. And our hope that all of this, the outcome will be to increase the career mobility for peers and reduce unnecessary hurdles for their credentialing by eliminating those duplicative trainings and creating clear pathways, and then removing unnecessary barriers for people with lived experience to enter into behavioral health professions. And I think this is something where, particularly as we're looking at our work with an equity lens, because of sort of the systemic inequalities that we have had since time immemorial, people who are part of BIPOC, Latina, Native, and LGBTQ plus populations are more likely to have had sort of contact with the system that's potentially going to bar them from being able to do this work. And those are exactly the people who we need doing it. So I think this is something that, particularly from an equity lens, is really important to continue making progress on. Next slide, Chad. And then just to outline some of the potential barriers to this, and I think for this, it's sort of one of the reasons to be aware of these barriers is I think having sort of the stamp of approval of the Behavioral Health Talent Council is one of the things that will potentially help overcome these barriers. But we do have sort of this systemic inertia of systems that were built around sort of an older model of who was going to be providing care, what the background of the people providing care was going to be, what the system was for sort of them to sort of enter into the profession. And so I think there is an extent to which this is sort of a moment where we need to be willing to say we need to look at those models, reevaluate them, and create some that work better for sort of the population that's really coming in at this point. And then, of course, the stigma around mental illness, stigma around substance use, stigma around having criminal justice background. And again, I mean, as we are seeing peers become so central to our workforce, and people with lived experience who aren't peers, who are moving into other roles and positions, becoming so essential to our workforce, I think really fighting that stigma is an underlying sort of conversation to everything that we're doing here in the Behavioral Talent Council, is being able to elevate that idea that like we are we can't be thinking about things the way that we used to. We really have to be embracing that lived experience and embracing the people who bring it to the profession. So that's everything for this action plan. So I think we're going to turn off the PowerPoint briefly to give people an opportunity to discuss before we move on to the next one.
Yeah, if you have any feedback, you can feel free to unmute or just pop something in the chat, whatever you'd like.
This is Ebony. I'm driving, so apologies for being off screen. Just want to say, just appreciate kind of the recommendation and the thought, because, I think as a system, it's important that we are leveraging all of or pulling all the levers to help evolve our system. And, I think that while we know where we need to go, oftentimes we're held back because of old policies that, I'll use the term are archaic. And so just appreciate the thought and intent and willingness around this recommendation.
Thanks, Ebony. Appreciate the input. Anybody else have anything they want to share? Go for it, Rachel.
Thank you. Just adding on top of what Ebony shared, I think the intent of all of the things that our group talked about removing barriers is so important, because it really cuts people off from moving forward. And as we remove those barriers, I just want to put a finer point on ensuring that we support those with lived experience that come into the profession, and that we don't forget that.
Yeah, I appreciate that, Rachel. I know that one of the things we talked about in our subcommittee is that almost all of us in behavioral health have lived experience. So that includes the peers and everybody else and how are we thinking about supporting them in the process as we go. Casey, anything you want to add to that?
No, I really appreciate those comments. It was a really fantastic discussion in the subcommittee, I think. And like I said, I think even the fact that we are talking about it in this group and the fact that people are feeling more like they can share that they have lived experience and that that's something to be proud of and not something to be stigmatized. I mean, I think that's fantastic. It feels nice to me.
I agree. I agree. All right, I'm going to keep us on time, and Casey, kick us over to your second plan.
All right, so this is our plan for supporting licensees and reducing barriers. This is one that we've sort of worked on from the beginning of our work as a subcommittee. We have had a few meetings on this one, and so there are a few things that are kind of contained within here, but I will try to break them out and happy to sort of answer any questions that come up about them. So our goal here was to streamline the licensing process and support workers who are seeking licensure by improving access to resources and guidance, exploring alternative pathways to licensure, and improving access to clinical supervision. So we were looking at resourcing our license boards to give them the ability to process applications and provide customer service at the level that they want to. Examining and implementing alternative pathways to licensure for applicants, which allow them to potentially be licensed without passing the test, but with additional sort of qualification guardrails to make sure that they are qualified to do the work. Supporting test preparation programs through both licensing agencies and providers, and exploring pathways to reduce pressure on supervisors to bill hours rather than providing meaningful support and preparation to their supervisees. All right, next slide, Chad. So I wanted to give a little bit of background on this one because I think a lot of what was in the Talent Council report and a lot of sort of the information that we had initially was very much focused on like bringing down times for licensing, bringing down sort of times for people being able to answer questions at the licensing boards and everything like that. And so we really wanted to look into that as we were making these recommendations. And I think what we found, and really appreciate the partnership of Ray and Larry at MHRA, or Todd and Larry at MHRA, Ray at BLSW, who helped us sort of put together some of this information. There's already been a significant amount of progress on this. And so as you see here, the average licensing times for the boards under the LPCT and the Board of Psychiatry are 2 days and 1 day, respectively. Under the Board of Licensed Social Workers, that's 30 days, although that is from the initial submission to approval. So I don't know if that's necessarily an apples to oranges comparison, but regardless, it's significantly less of a problem than we heard people saying it was a few years ago even. And similarly, they've set some very specific customer service targets in terms of how quickly they're able to get back to people who reach out to them with questions. And so I think as I note down at the bottom, as we've had these conversations with the licensing boards and with the people who interact with them, the current major limitation on the state licensing boards is their licensing system. It's an outdated system that's preventing their employees from operating at maximum efficiency, preventing them from being able to turn around licenses with as little work as possible, which would then leave them more time to be doing direct customer service, to be doing policy work, all the things that sort of they do behind the scenes in addition to their licensing jobs to continue to make improvements on the system. So next slide, Chad. So we are recommending giving the licensing boards the resources that they need to update their joint licensing system. This is something that is already in the works behind the scenes. And so this is something where potentially we would just be asking the Talent Council to sort of support that ask as it goes forward. But that is something as we looked at all the ways we can streamline this, this was sort of number one with a bullet in terms of like the amount of return that we would get for the investment. We want to expand access to licensure by exploring responsible alternative pathways to testing for qualified applicants who struggle to pass the licensing exams. This is one, and there's some more information on a later slide about this, but this is one where I think we really did flesh out the tension that exists in this space, particularly in the work the Behavioral Health Talent Council is doing, between wanting to make sure that we are protecting consumers and putting people into the behavioral health workforce who are prepared to do the job, who are not going to feel overwhelmed or burnt out because they haven't been given the proper preparation and training, and also eliminating unnecessary barriers, eliminating things that don't need to be there, making sure that people who are qualified to do the work are able to do the work. And so what we ended up recommending out of that meeting was looking at alternative systems. And we don't sort of prescribe, I think it makes sense to let the boards have these conversations, but looking at alternative systems for applicants who have tried and failed to pass the test. There are some states that have just eliminated the test entirely, but there are others who have just created this alternative pathway where if you try and fail to pass the test, you can perform additional supervised hours and then submit letters of recommendation from your supervisors to ensure that you are meeting the qualifications that are needed. So again, that would need to be a conversation that would occur in the boards, but I think it is an important one to have because there are still significant, particularly racial disparities, but also disparities for people who are multilingual on those tests. And we know that those are both areas where we really need to be supporting more people coming into the workforce. And then supporting applicants by providing accessible test prep. This is something that MacBo had a grant to do up until recently. They were providing test preparation to the people who are taking their tests. This is something we could continue to support there, potentially expand to the other licensing boards for a relatively small investment. But the other thing that came out of those conversations that was really interesting was some work that Summer is doing down in Central or down in Southern Oregon around providing test prep through to their employees through the provider, creating sort of like test preparation study groups, giving them the preparation materials. And it sounded like that was something that was significantly having a significant positive impact on the workforce. So that's something I think that we should explore as well, is creating resources for employers to sort of do that themselves. Next slide, Chad. Continuing to improve the efficiency of the licensing process and availability of service and supports to applicants. That would potentially, this is the key goals and outcomes. So this is not new things. But yeah, we were wanting to increase that efficiency, to bolster morale, free up resources, and make sure that qualified applicants are making it through the licensing process to be able to practice. And then expanding and improving the workforce by creating pathways other than those that go through the sort of traditional manners that we know for some people can be sort of an impassable impediment. And certainly for some that is a necessary filter, but for others it's potentially keeping them from being able to work even if they would really want to do the work and are qualified to do it. Next slide, Chad. So this is that future slide that I was referring to. So the barriers on sort of these ones, we are looking at sort of just the reality of having to fund the things that we need to be able to do some of these things. There would potentially be fiscal resources necessary for the test preparation, also necessary for the new agency licensing system. And so as we are looking through sort of all of our potential fiscal asks from the BHTC, that's just something for us to look at while we're prioritizing those. And then as I noticed, while the data does show significant racial disparities in first-time passage rates for the social work exam, and I was not able to track down similar data for other behavioral health sort of exams, the surveys of their workforce indicate sort of a pretty significant approval of maintaining those tests. So the importance of the test, not wanting to get rid of it, and that actually extended even into practitioners of color. I think it was something like 72% regarded the test as something that should be maintained. So that's why, as we were looking at recommendations, we really didn't want to look at the elimination of the test. We just wanted to look at how do we create a way for people who have tried to take the test and have not been able to pass it to potentially be able to have another way into the profession. I think that's the last slide, but check if there's another one, Chad. No. Okay, excellent. We're good for discussion now.
That was brilliant. I will say I appreciate the attention that you all paid to the how people are feeling about the importance of the tests, because I think that's there. And knowing from my own as a social worker, like just saying, oh, we should make the test go away, there would be so much pushback on that. So I'm grateful that there was some attention paid to how we can create other opportunities without just saying we don't require a test. So thank you for that. Other people that want to jump in, Alice.
Yeah, I just want to appreciate the work of the subcommittee and also um, that's such a creative response to sort of give multiple options. I think again, like Robin, what we've heard is like cancel the test um, and I guess one question, this is maybe too granular for our group, but is I think it would be important if people are going to have these alternative ways of verifying, preparation for practice to communicate that what is the value of studying for a test that you may not pass. Because I think there is some cost involved when people are not, I mean, there's literal cost, but then there's also psychological cost to people for whom test taking is not a strength. And so to really articulate, like we see value in studying for this test. And then I also I was thinking about, yeah, the additional sort of time involved in after studying for and not passing the test, doing the extra supervision and so anyway, I just like I have a lot of questions and I'm super excited to hear about this proposal.
I appreciate that feedback and the question, Alice. And I wonder, Eli, like, do you have a response to what Alice is saying?
I'm not specifically to that question. I was just going to add a little bit more insight. I think, once again, like when we had this discussion, it wasn't like one or the other, right? Protest, no test. It was trying to develop a healthy balance. And I think the input that I was able to provide, and I believe Ebony as well, was as individuals and people of color, we recognize how challenging it was for us to do that psychometric exam, that wasn't really culturally responsive and then as social workers, what was so challenging was that we had to wait 2 years before we could take the test. Whereas, licensed mental health intern, they can do it immediately after, while in their graduate program, or even directly after. So there's a significant discrepancy between the boards and when you can take the test. And I think for us that we had that very robust discussion on how do we address that, right? And how do we kind of reduce that barrier around that. So there were some very strong talking points, and I really appreciated and valued everybody's input in that conversation and discussion.
Thank you for the added insights. That's helpful, Eli. Ebony, did you want to jump in?
Yeah, no, thank you, Eli. I was also going to just say, a part of the discussion that we had was also, and this is what I had brought forward, was that, the reality is because of racism and implicit bias, um, there's going to also be kind of that narrative or thought or assumption that if someone is brought in through an alternative pathway, that that they technically are not qualified
Mhm.
or fit for the role. And so I talked about the importance of being able to demonstrate some levels of checks and balances, and there's probably a better way, or phrasing to help dispel some of that assumption. So because that's hard to navigate too. And so those are just things that will have to be thought out. But that's just another piece of the reality.
Yeah. Thanks for flagging that, Ebony. I agree with you. Rachel.
Thanks. So, as the non-social worker, mental health in the group, I thought I'd share in this space with the whole group. Like, I was very passionate and somewhat appalled about the differences in how much support nurses get to understand this test that has been tried and true and supported, and everyone takes it, and that during your education, you are supported and understanding to take it, and then you are encouraged to take it very close to graduation. And so I was really surprised and shocked. And then that's not Oregon. It sounds like that's national, but this is a conversation that if it's being had, it needs to be louder because it was really surprising to me. Because even just looking at what we're trying to do at the Board of Nursing to support the CNAs from not falling through the cracks, which is as they have to take some of their testing, even if they have to go somewhere and wait 6 months, they can fall off and we're losing them. So how do we improve that? So I hope one of the things that comes from this is that has to be louder, not just here, but on a national level. And then to speak to what Ebony said, I did bring up how nurse practitioners are constantly being challenged by the medical association that we are not good enough and our training is not good enough. And so whenever you look to changing anything with alternative tracks or not the test, who's going to do that to that profession and to make sure that doesn't happen? And so I do think there's way to come to improve this without these really harsh answers. But yeah, I can't wait to learn more about the discrepancies of supporting a student to take the test and to take it sooner, moving forward.
Thanks for lifting that up, Rachel, and just for sharing your experience outside of those other areas of focus. Thank you. Shira.
I have 2 points, one being like concern about it, and then the other, I think maybe like a reframe in how we talk about it. I'm an LPC, and kind of similar to some of the points that have been made, like I worry about behavioral health providers already being hyper scrutinized for our capabilities and our education and underpaid given the amount of education and training that we have, right? And the all of the layers of administrative burden, all the things that go in around accountability and like just how this type of change would impact people's perception of our qualifications. I also think about like the different levels of respect that the social work board has versus the LPC board, the lobbying support that the social workers have. There's really specific jobs sometimes that will require an LCSW and not an LPC, even though we're equally qualified. And so I worry if like one board, like say the LPC board, were to say, yeah, we think this makes a lot of sense and we want to honor, the challenges and the racial disparities, but the LCSW board says we don't think so, that could again create more discrepancy between how the professions are seen and valued. So I worry about that. And then I wonder if in just like, because I do support it as a strategy, generally, I just worry about the social and professional implications of the change. I wonder about rather than thinking like test or no test, and I appreciate that that's kind of not really how it's been framed in this recommendation, but it's that that the strategy is broadening of competency, like a broadening of our strategies to measure competency. So it's not you're taking a test or you're not. It's that we're adding a couple of other measurable ways to see if professionals are competent and ready. And then you just have a couple of different tracks, right? And I think that that will sit differently for people than a test or no test, or you're exempt from the test, right? Because we're going to let you be in a special category or whatever that people want to make up about that.
Yeah, thanks for sharing that. I'm wondering, Casey, as we're getting so much great feedback, is there a way to capture this, specifically around language and just adding some more depth to the recommendations?
I am taking notes and we will definitely follow back up on all of these to figure out how best to incorporate it into the final product.
You're the best, Casey. Thanks. All right, Jamie.
Thanks. I just wanted to echo, I love the idea of the tracks as far as right, you could take the multiple choice test, or you could maybe some track is a discussion conversation one-on-one with some type of professor. I don't know. And I feel like in academic environments, sometimes they can make those accommodations. And so that's cool. I guess I was wondering, and you probably considered this, I'm out of my depth here. Do you consider the threshold for passing, the floor for passing? Is there a discrepancy between that? Maybe we need to ask the psychologist this. Is there a threshold passing the LPC versus passing the LCSW? I was just curious if there's any work that could be done there that would be beneficial that people don't even realize, oh, I passed. What was the threshold to pass? I think the threshold to pass the LPC was fairly low. But again, yeah, I was the little brat whose mommy bought her like a book to study, right? So also making sure people have access to those resources for free. Um, and yeah, anyway, I just thought that if that's an easier solution to just tweak the threshold somehow.
And I believe that is set nationally for the social work exam. So that is, doesn't mean we couldn't figure out potentially creative ways to help people be able to reach that. Looks like Van has his hand up, so I'll pass off to him to see if he has something to add about that question.
Yeah, and can y'all hear me first? This is not my normal computer. So Casey, you're right. It is set nationally, the cut score. It's because these are all national exams. Now with ours, so we do the portfolio review process, but the person has to attempt the exam before they're eligible for the portfolio review. And then the requirements from taking the exam to getting the portfolio review pretty much double. So for our CADC one, they go from 1,000 hours to 2,000 of supervision, and they go from 150 education hours to 275 education hours. So you're exactly right when you say it's another form of measuring competency. And that's really what it's all about, is just how can we make sure everybody has a path in, because like Eli was saying, some people, spend 2 years getting all their education and they can't pass the exam. Some people have testing anxiety. There's multiple reasons, why it's nice to have an additional track. And just knowing that there's an alternative pathway is I feel like really comforting to people to know that they can pick this profession and that they will be able to move forward through one measure of competency or another. We do maybe 10 portfolio reviews every year. So, we have over 20,000 active people. It's not widely used, but the people that do use it are so appreciative of the option. And we've had it in rule for over 20 years. So it's been very successful for us.
Yeah, thanks for sharing that. It's good to hear other ways other folks are doing it. Clarissa, you want to jump in?
I just had a question for Van. How many people on that alternative track actually succeed in getting in passing or getting, that credentialing?
Well, they would have to attempt the exam first, and then they could go and get a portfolio review. Now, sometimes we have people take the CADC one, they fail, they get a portfolio review. Years later, they want to come back and get a CADC two, which is a different exam, and they have to take it, and then they end up passing it. So sometimes it's just getting over the hump. Um,
How
but
many
yeah,
people pass during that initial portfolio review? I guess is what I'm wondering.
um, right. So they wouldn't apply unless they're qualified. So they would just have to show that they meet the requirements for the portfolio review, which, like I said, for CADC one would be double the supervision and almost double the education. And then we would just review all of their documents as a whole and then say, you're eligible to move forward and give them a credential number and without passing the exam. And we would make an internal note, but there's no note on the registry that says this person's a portfolio. So to Ebony's point, everybody ends up at the same place. So only we would know this information.
That seems important. That's great. Thanks. I just want to thank everybody for taking the time to share their thoughts and comments. Clearly, this is something that there are feelings about. And so I think it's important that we lift that up. And Casey, thank you for taking notes and hopefully carrying these concerns and ideas forward, because I think it will help make the recommendation even stronger. All right. Julie, ready to jump in with the next action plan?
Yep, ready to go.
Fantastic.
Go through this pretty quickly because I know we're a little behind. Okay, good afternoon, everyone. Today I'm going to present the action plans for administrative burden and compensation from the Recruitment and Retention Subcommittee. Next slide, please. The first action plan is administrative burden, the purpose of which is to reduce behavioral health worker burnout with improved client care by cutting unnecessary paperwork and administrative tasks through new rules, technology, and templates. Here are the three focus areas. Review and simplify administrative burdens to strike a balance between ensuring high-quality care without overburdening providers. The second is to address administrative burden by rethinking, revising, and simplifying reporting and billing, and eliminating current redundancies in process and protocols. And the main focus components are rule revisions, technology integration, standardization, oversight, and support. OHA will be the lead on this work plan in partnership with provider organizations, CCOs, CMHPs, and consumer advocates. Next slide, please. Here are the key strategies and actions. The first is to standardize charting and documentation templates and the use of technology to reduce documentation time. The action for this strategy is to research AI technology and provide guidance on use of AI and provide standardized EHR templates for all clinical documentation. The second strategy is OAR changes regarding documentation. The action for this is to streamline processes by using AI to assess OHA rules and policies to minimize documentation requirements. An additional action here is improving oversight by shifting audits to focus on client outcomes and technical support rather than just pure compliance. This would include providing technical assistance to organizations that are struggling to meet standards. The third action for this strategy is to create a centralized credentialing portal developed by OHA, which CCOs will be required to use. The third strategy is to define and protect dedicated admin time. This will be accomplished by defining paid administrative time in contracts. And finally, the fourth strategy is that OHA will adopt the mission of minimizing admin burden by a centralized grant and reporting unit across divisions. The action for this strategy will be for OHA to develop a cross-agency reporting unit whose job will be to eliminate duplicative reporting requirements and expectations. The second action for this strategy will be to establish an admin burden governing body consisting of representatives from providers, CCOs, CMHPs, and consumer advocates to oversee all clinical documentation and reporting requirements and report biannually to the legislature and governor. Next slide, please. Here are the key outcomes and goals for this action plan. The first outcome is to have standardized templates and integrated technology for charting and documentation. The goal here is to reduce documentation time and increase work satisfaction and retention for frontline staff. The second outcome is streamline rules and policies, which entails the removal of duplicative and low-value reporting. The goal of this outcome is to reduce workload on individual providers and their employers. The third outcome is to protect admin time for the workforce. The goal of this outcome is to optimize the delivery of services using resources more efficiently and effectively. And then the fourth outcome is less duplicative reporting across OHA divisions and better attention to high-value reporting, resulting in fewer administrative staff required at provider organizations. The goal of this outcome is to reduce organizational burden costs so that money can be repurposed for higher salaries for frontline staff. Next slide, please. There are three equity issues identified with this action plan. First is administrative burden disproportionately impacts marginalized groups and the frontline employees who serve them. Second, for staff, the burden translates to burnout and stress. For consumers, they can experience frustrated and dissatisfied service providers, which erodes the therapeutic alliance and diminishes quality of care. And third, an equity lens during organizational administrative process auditing will reveal how administrative burden inequitably affects different groups. Next slide, please. Now, there are 5 key anticipated barriers. The first one is, of course, the obvious concern for privacy with the use of AI that integrates with EHRs. There's a lot of fear and concern about that. There is the cost of AI software, which I have experienced myself in my own agency, especially if you do not have it integrated into your EHR already. Changes to audit standards will require state plan amendments. CCOs will need to buy in, and implementation could be slow. Federally established Medicaid regulatory standards will require a bipartisan effort with other states to identify a shared ask for reduced regulatory requirements that are overly burdensome. Now, we anticipate about a 6 to 12-month timeline for most of these deliverables, with ongoing evaluation and refinement. So at this point, I'll pause for questions. I'll also invite Amy to help me answer them. I think Amy's on the call, right? There she is.
It's good to have backup, right, Julie?
Yeah.
Rachel.
Okay. I am really thankful you all did this work. So everything I say is nothing against all of the great work. I'm glad that I wasn't on your subcommittee, because just hearing all of that brought me back to what burnt me out and why I'm in the position I'm in now. So I'm going to be kind of honest. I think that anything that OHA can do to remove admin burden is awesome for them to be in charge of. Things that maybe aren't them causing admin burden, all of the people on the front lines can fix that probably on their own. And hearing what you all are up against in that group, again, I admit I'm putting my own, it just all came back. Templates, all of these things aren't going to do what we need until we as a state invest in one EHR, or as a country. We created this, here we are, we're transitioning. And I know some of you, like me, went from paper to EHR, and we're not even all on the same EHR, even now when things happen. So to me, scribes in one EHR would be the investment. Work groups and OHA overseeing streamlining, removing admin burden. I'm sure every single person in this group has already been a part of something like that. So again, I say this all with love, but with my own burnout and just thinking about it caused it. So I I'll stop there, and then someone can tell me to be quiet, or understand that you all probably went back and forth in your subcommittees that with the same kind of pains.
I appreciate your comments, Rachel, particularly about the one EHR. I know in my agency, we've talked a lot about that. Our desire for all to be all on one system, and to have it funded at least through grants would be awesome. Amy?
Yeah, that would be amazing, wouldn't it? And it's yes, that would be amazing. And I think, sort of given the fiscal climate we're in right now, that didn't seem like that seemed like high impact, low feasibility. I will say that, and I say this lovingly, that I think some of the admin burden that providers are dealing with has accumulated over time from a variety of places. Some of it comes down from the federal government. Some of it comes from the legislature through like various bills that get passed. Some of it is rules that OHA rolls out. And to my awareness, there is really no one entity that actually holds all of that information. And so what I have seen over time is that we spend countless hours talking about how terrible it is, but we don't even have our arms around what all that is. And so part of what we talked about in our admin burden group is like let's use AI to do an assessment of what all the reporting requirements are so that we know what that is, and then develop a process to go through and figure out where it came from, what's actually required, what we can get rid of. And then the governing body is like, how do we ensure that we don't end up in a place where stuff just gets added and then we never take anything away. So, humans love, like, we love to do things, we like to create new things, and we hate to take old things away. I mean, look at my house.
Yeah, I appreciate that. And I think, there's probably a great jumping point then to start from with all the other groups that have looked at admin burden. And if the goal is to look at what has been put on by OHA or legislators, versus the things that we can't change, then that's a great goal. Like, put them all on a list and say, let's repeal this, get rid of this. As my beginning presentation was when we first started this, was what I did to look at the statutes and the rules that we had and go, why do we have this? Is it actually public protection? And if it's not, then let's get rid of it. So if that's the goal, I'll reverse my crankiness and support you all.
It's
Thanks,
okay to be
Rachel.
cranky. Shira?
How about Jamie? You want to go?
Cool. Thanks, Julie.
Oh,
I
sorry.
forget.
I thought Shira was first. Sorry.
Oh no, I thought the computer lines is up, so I don't know. No offense. It's neither here nor there. I think either courage to remove things, which can be scary, or just building in the culture of not adding things, or when we're adding things, we're being extremely mindful of like what the report is being used for. My team submits, I don't, 29 reports every quarter on our hold and seclusion data. Sensitive issue, right? But 29 reports to 2 different entities because people want the different, and I have to legally publish it on my website for just the general public's consumption. So if people are afraid to kind of say, okay, we don't need all of that, also none of that reporting has anything to change the decrease in hold and seclusions, which the meetings that we're required to have on the issue would have much more of an influence over than just the reports that honestly I don't think anyone really looks at. I think you couldn't be looking at 29 reports a quarter and making some kind of meaningful conclusion. Or we certainly don't get any follow-up or any response to those. And so if we're not afraid, if it feels too sensitive to actually take things away, how could we build a culture of really questioning? It's so easy to be like, I'll do a report, to Amy's point, during state audits. I'll go, oh, we'll do a report to show we're compliant on this audit finding. And now I've done it to myself. And then they say, great, send us that report every month. And we send it for infinity and beyond, and no one ever really looks at it. So I think best bet is probably just to change the culture and slowly chip away at it. That's my only hope for also feeling burnt out on this issue. So
Thank you, Jamie. Shira?
I mean, I think Rachel, your like skepticism and like frustration is like so shared. And I was also on this committee, right? And so I think it's like, was that actually going to get anything done? Because I mean, I've spent umpteen hours on different work groups talking about administrative burden where OHA was present. And I think it's the disjointedness that's so frustrating. And so I do appreciate like the centralized approach here of like one entity being responsible for knowing and evaluating what the holistic administrative burden is. I also think that representation in that like committee and work group is really important in that it won't just be OHA staff, but there should be CMHP directors and provider directors and others who have like boots on the ground knowledge about how things actually feel and how it plays out. So I just wanted to add that piece.
Yeah, and one of the ideas behind that group and it being ongoing is so that we don't drift back into old habits again, that we keep reviewing the criteria for keeping documentation streamlined, necessary, easy, etc. Clarissa.
And just to go back to the EHR idea, one thing that we talked about ad nauseum, or at least I talked about ad nauseum in our subcommittee, is that, behavioral health encompasses medical providers and people who provide therapy. And those two worlds do not often mesh well. So like with an EHR, I happen to work in an integrated behavioral health FQHC. We are struggling so much to get Epic to work for our therapists. And Simple Mind or something like that does not work at all for medical. And so we really need to partner with, that idea of having one EHR. I love that, but we really need to partner with somebody like Epic to be like, hey, we need a whole behavioral health part of Epic if we're going to consider, or whatever it be.
Yeah,
I'm
they
just
need to do
using
better.
Epic.
I love that. They need to do
Exactly.
better
So
because they want everyone to be on it too. They need to do better than for mental health. Huh.
So
Yeah.
we've been going back and forth almost ad nauseum, almost like banging our heads against the wall with like, hey, this doesn't work for medical providers, but we're part of behavioral health. So it's been really challenging, and I just appreciate the subcommittee so much.
Yeah, it's a common complaint I hear about Epic.
That's why we're not on it as a behavioral health provider, because it doesn't work for us yet.
It's also
And
very
it's really expensive.
Yeah.
Yeah.
Yeah. Any other questions or comments? Thank you. Thank you so much. I appreciate the input. Okay, I'm going to go to compensation. Thank you. The purpose of the compensation action plan is to reduce pay disparities, recruit and retain specialized workforce, and establish a more equitable reimbursement structure. There are 3 focus areas for this plan. The first is to address inequities between community-based and private practice providers. The second is to explore and fund financial incentives for specialized workforce roles. And the third is to develop progressive reimbursement rates and billable services that currently undervalue community-based healthcare and fail to keep up with rising operating costs. The lead on this plan is OHA in partnership with HEC, the CCOs, and the DCBS. Next slide, please. There are 4 strategies for this action plan. It looks like 5, but 2 of them are kind of duplicative, so I'll explain that in a minute. The first is to define and implement updated rate methodology for high acuity community-based providers. The action for this strategy is for OHA to develop criteria and methodology for identifying high acuity service providers and apply enhanced reimbursement rates. The second strategy is to incentivize specialized workforce roles. The action is for OHA to modernize Medicaid behavioral health billing processes to incentivize providers who offer crisis services, culturally specific services, or services in rural areas. The third strategy is to develop a progressive reimbursement model, and there are 2 actions for this strategy. The first is for OHA to develop a legislative concept for biennial rate adjustments tied to inflation or cost indices. And the second is for OHA to develop a funding framework that provides for progressive rate adjustments for new services commensurate with existing service contracts. The fourth strategy is to establish crisis stabilization billing codes. The action here is for OHA to implement new billing codes for short-term crisis stabilization services for Medicaid and commercial payers. Next slide, please. There are 4 key outcomes and goals for this plan. The first outcome is a policy framework and incentivized rate schedule for high acuity provider compensation, the goal of which is to reduce pay disparities between community-based and private practice providers. The second outcome is incentive program guidelines and funding proposal, the goal of which is to incentivize and retain specialized workforce roles in high-need areas and populations. The third outcome is CMS-approved billing codes and provider guidance, the goal of which is to establish a sustainable, equitable reimbursement structure that reflects service complexity and supports culturally responsive care. And the final outcome is increased payment for crisis services and incentivized crisis work, the goal of which is enhanced and stabilized crisis system for HR1 implementation and Medicaid churn. Next slide, please. There are 2 equity opportunities that we've identified for this plan. The first is to expand access to culturally and linguistically specific services by supporting workforce development and compensation. And the second is to ensure that rate setting and incentive structures do not inadvertently exclude smaller or under-resourced providers that may not have economies of scale. Last slide, please. Now, in terms of implementation, we anticipate barriers in three major areas: cost, operational, complexity, and communication. In terms of cost, rate increases and incentive programs will require legislative appropriations and CMS approval. The infrastructure for new billing codes and program oversight will require additional staff and system updates. In terms of operational complexity, needing to define high acuity and specialized roles in a way that is equitable and administratively feasible, and then ensuring alignment across funding streams. And then finally, in communications, there will need to be clear messaging to providers about eligibility, rate changes, and incentive opportunities. The close coordination with CCOs and provider networks will be needed to ensure intake and compliance. We anticipate a range of anywhere from 6 to 24 months for most of these deliverables. Okay, comments?
You moved through that fast, Julie. Thanks so much.
Sorry.
No, that was to the point. I appreciate it. Any thoughts, comments, feedback? Go for it, Ebony.
Hopefully y'all can hear me okay. Can everyone hear me?
You're cutting out just a little bit, Ebony.
Oh.
No, I don't hear you, Ebony.
Right.
You're still breaking up, Ebony.
Now.
It seems like your connection's not quite good enough for us to hear you, Ebony. Okay, so while we wait for Ebony to maybe get in a better spot, does anybody else have something to share? Any feedback? This is an important one for sure, and appreciate all the hard work and the structured suggestion of tiers. That makes a lot of sense. I do want to, yeah.
I just wanted to take a moment to acknowledge the OHA staff and the governor's staff for helping with these plans. They've really done an awesome job. A lot of heavy lifting. I'm just reporting.
Yeah, and thanks, Amy, for showing up.
Can everyone hear me now?
Yes.
Hey, yay, awesome. I think these are all good recommendations, and again, not being a complete CMS wonk or guru, I do think that that understanding that there may be some feasibility issues, especially for the ones that require approval through CMS through spot change. And so I just want to just highlight that some of this, might be easier said than done, but so just really being able to, some of these will require understanding, how far we can get within, Medicaid rules.
I appreciate that, Emily, and I think that my subcommittee is well aware that there's some pretty challenging goals here.
Yeah, and we go into it doing the best we can, yeah?
Yeah.
All right. And thanks for lifting that up, Ebony. Like, it's always good to know. And remember that there are challenges in front of us with each of these action plans. And so, especially some more than others, such as compensation for sure. So thanks for that. All right, I'm going to go ahead and move us on. Thank you, Julie, and the subcommittee for all that hard work. Let's just take 5 minutes, y'all, to stretch, grab something to drink if you need it, and we'll come back at 2:15. Sound okay? Thanks everybody for starting to come back. I know 5 minutes just doesn't seem long enough for a 2-hour meeting. Like just a few more minutes. Thanks for jumping back on. So you've got me for the rest of this. We're doing the education and training action plans, and then we'll wrap up. We've got 3 action plans. I'm going to try to move through these pretty quickly. I'm hoping that folks had a chance to review them. So we'll go through each one of them, but just know if you need more information or have questions, there will be time for that at the end of each one. So thanks, Chad, for getting us queued up right away. We're ready to go. All right, so I'm going to jump in with this first one, which is around enhancing partnerships and collaboration. So the first plan focuses on strengthening the connection between education providers, employers, and community organizations so we can create more clear, accessible behavioral health career pathways across Oregon. So there's hold on a second. I'm trying to figure out where we are um can you just go to the next slide real quick, Chad, and then we'll go back? Okay, yeah, okay. And now you can go back. Okay, so really what we're trying to do is figure out how do we strengthen these partnerships and focus on those 4 key areas around early career experiences, paid internships and apprenticeships, launching statewide behavioral health career consortium, which we've talked about in the past, and then advanced credits for learning, which we want to try to lift up. So next slide. The strategies and actions are really these 4 things that we've got listed out. So the first is piloting early behavioral health career experiences, things like job shadowing, peer mentorship, and wellness ambassador programs. These would help students get a better understanding of the work and start building confidence early on. So that could be really important. Second, we're suggesting that they expand paid internships, apprenticeships, and supervised placements. And we all know that these are essential for both access and retention. The third strategy is launching a statewide behavioral health career consortium, and that will really help with creating a unified message across agencies and institutions, and hopefully help with coordinating events and recruitment efforts, and so helping everybody sort of be tied in together. And then the fourth strategy is around advancing credit for prior learning so that people with peer experience or workforce training can get academic credit. And hopefully move them along further in their degree pathway more quickly so that they don't have to kind of trudge through it and redo stuff that they've already done. And all of these are connected with the shared outcomes. And so looking at outcomes and goals, please, Chad. Awesome. So these ones are pretty straightforward. We want to get folks earlier exposure to the field. We need high quality paid work-based learning opportunities across the state. We need consistent statewide messaging about career options and stronger recognition of lived and workforce experience. So ultimately, this is about building a diverse and culturally responsive workforce and one that reflects the communities that we serve. So what we know is that equity, of course, is embedded in every piece of this. And so if we go to the next slide around equity opportunities, please. This plan directly advances equity by creating culturally responsive entry points to the field. And so we're intentionally suggesting partnering with tribal education programs, BIPOC-led organizations, and peer-run groups to design experiences that resonate with different communities. We're also focusing on rural and frontier gaps, especially those regions where they have limited access to internships and training, and that is a tough space to fill and that needs to be paid more attention. We also know that by prioritizing lived experiences and voices and expanding access to early opportunities, we're helping people to see a future for themselves in behavioral health. Because so much of the time, people don't even know what we're talking about when we say behavioral health. And so how do we get people into those spaces? But of course, as we're looking at opportunities, we also need to look at what could be challenges. And so if we go to the implementation considerations on the next slide, Chad. So you'll notice there are a few key barriers, and often, they show up in every one of these action plans. Funding and staffing limitations are tough, especially if we want to try doing pilots and create sustained partnerships It just takes time and people. Data systems aren't aligned, which affects our ability to track outcomes. Digital access continues to be a problem in rural and low-income areas, and even beyond that, just like we were just talking about in the last action plan. And we still see underrepresentation of BIPOC and multilingual professionals in supervision and mentorship roles, and that's an ongoing issue that needs to be addressed. Most of the deliverables for this plan are doable within 3 to 9 months, and that is going to take some continual refining and adjusting to make sure that that actually rolls out the way that we would want it to. So let's pause. That was a lot in a very short period of time. Any comments from anybody else in the committee or questions from folks? Pretty straightforward. Yeah. Okay. Should we go to community college collaboration? All right. Thanks, Chad. So our section action plan zeroes in on community colleges, which play a huge role in Oregon's behavioral health pipeline. And so I just want to acknowledge that before we get into it. We've seen declining enrollment in some behavioral health programs at community colleges, and we need to figure out what's happening so that we can help address those patterns. So here's what the talent assessment told us, and we're going to go into those focus areas on our next slide. Thanks, Chad. So what we know is that, oh, nuts, I'm ahead of myself again. If we can go back, the two big things that stood out in the talent assessment and the last one are enrollment in behavioral health programs at community college, and then the transfer process. Those are often inconsistent and they can be confusing. So this action plan addresses both of those issues by analyzing enrollment trends, piloting cultural responsive on-ramps, improving articulation and credit mobility, expanding regional partnerships, and building equity-driven accountable systems. That's what we're going for. So let's look at the strategies. That's our next slide. Thanks so much. So for our strategies in action, we're looking at 5 coordinated strategies. So the first one, analyzing statewide enrollment and transfer data. We want to make sure to be able to understand what's happening and who is being left out. First one. Second one, when piloting inclusive on-ramps such as dual credit for prior learning, peer pathways, especially as we're looking at rural, BIPOC, immigrant, and multilingual learners. There needs to be more ways to get into the field. Third, strengthening articulation agreements and transfer maps so students don't lose credits. That's a really important one and can be different between the different community colleges and one four-year institution. So how do we help strengthen those? And then the fourth one, expanding local partnerships to improve mentorship, field placements, and community-centered supports is something that can have a huge impact. And then finally, the strategy to build equity-driven accountable systems that track, transfer, credit for prior learning use, and completion across different student groups will be incredibly helpful. All of these strategies, if we can do that, are going to lead to these sets of outcomes that we've set up for you. So these include increasing equitable entry into the behavioral health pathways at community colleges, ensuring students can transfer efficiently and receive credit for prior learning, strengthening rural and regional capacity for placements and support, and building transparent data systems so we can consistently improve what we're doing. So this plan positions community colleges as essential partners in Oregon's workforce development, which is where they need to be. So let's look at the equity opportunities that are embedded in this. Thanks, Chad. So this plan in particular, I think, is incredibly equity focused because it's really thinking about designing or co-designing on-ramps with culturally specific organizations and peer groups to be able to make sure that we've got programs that are more accessible to students who have historically been left out. We're also hoping to address barriers related to language, advising, credit recognition, and geographic isolation, which are something that we deal with all the time. And if we can do these things, it's going to ensure that community colleges can truly serve in inclusive gateways into the behavioral health workforce. So there's a lot of great opportunities, but we also know that there are some challenges. And Chad, if you could move us to that. So there's several constraints, and again, they're going to look very familiar. So one, funding and staffing shortages make it difficult to expand supports. The data systems are fragmented and not all colleges track with the same indicators. and we can be very sort of siloed in that way. And then students still face challenges related to advising, digital access, language, and awareness of pathways. So even though there are some really clear ways we can make a difference, there are some things that need to be addressed. The timeline for this is, we think, within 3 to 12 months. And that's going to have to obviously be observed and evaluated as we go. So let's again hit pause. And I want to invite Monica. I don't know if there's anything that you want to jump in and share from the community college perspective. You were a big part of helping bring this to life.
No additions.
No. Okay, thanks.
I mean, our committee talked a lot about this, and I felt like there was really a solid openness to hearing the struggles that some of the community colleges face, and how do we reconcile some of those challenges. So I feel positive about where this action plan landed.
I appreciate that. Yeah. And I think that one of the things our committee talked a lot about is that we need to make sure that there are entries into the behavioral health field from so many different sectors and ways of practicing and engaging. So I'm glad that we could name the community college space, because that's a really important one. Questions, comments? Shira, jump in.
Know if this fits here. So if it needs to like live somewhere else, that's totally fine. But when you said, like enrollment in community college, like behavioral health participation is decreasing, I'm just recently I've had some experience of staff really struggling with increase in student loan payments, like triple what they had been paying before. And so like staff who have the luxury of getting health insurance and benefits from their significant others are going more into like the BetterHelp contracted $110 an hour fields, right? Where they're able to pocket more money because they have these really extreme student loan payments. And so I've been thinking about like all the conversations that we've had around loan forgiveness and tuition assistance. And I've never thought about like paying someone's loan payment as an incentive. Like, work for us, maybe we can give you some tuition, but like, can I also just absorb your monthly or like 50% of your monthly payment? As that seems to be like a factor for people now needing to leave the publicly funded sector.
I appreciate that, Shira. Yeah, that kind of expands outside of just community colleges. So I agree with you. Like, we need to name that and find a place where that fits, because we all know that's actually about to get worse, is that the amount of money that students are going to be able to get to go to college is being reduced. So Taylor, maybe you can capture that. We can find a place where that might live with the education and training action plans, because it needs to go in there somewhere. So thank you for that. Thanks for lifting that up, Shira. Clarissa.
Thank you. Just wanted to say that's an amazing amount of work that you guys put in. I'm just curious, so from the medical provider perspective, from the nursing perspective, so the community college provides a degree that is not a Bachelor of Science in Nursing. And to be in the hospital setting where a lot of psych nurses are employed, there would need to be like a bridge, or and there is a bridge down here, but I know that like, for instance, our community college offers a nursing program, but it's a lot smaller than the Bachelor's of Nursing program, and psych nursing tends to be a less I don't know how else to say it, a less sexy pathway for nurses. A lot of nurses, I mean, I think the numbers for nurses that specifically go into psych nursing is pretty low. And so if we're looking like at the community college that already has not as many students for nursing as like say OHSU in Southern Oregon has, and then we shrink down like the interest in psych nursing. I wonder if you have anything to say about that or address, or if your committee spoke on that at all.
That's a great question, Clarissa. I'm going to invite anybody from our committee to jump in. I will share from my recollection that we never broke it down to specific areas of behavioral health to talk about the pathways in. And it gets complicated because that's, as you mentioned, like Southern Oregon has a system and that we have those connection for pathways that work a certain way, and that's going to be different in the eastern part of the state or the, up north. And so I don't know that I have anything specifically to respond to your question about psych nursing, and wonder if anybody, Monica or Alice, if there's anything that you would want to add as we think about just those different pathways for different professions.
I mean, I know COCC was just approved for a Bachelor of Nursing pathway, but I don't know if it has I don't know how it addresses psych, honestly. It's, I think, new to us within the last year. But we were approved for that. So that's an exciting step, at least for us, to have the access to that pathway. But I agree, there's probably a deficit in the psych pathway in that educational section.
Yeah, thanks for weighing in, Monica. And one of the things I hope that will happen is as community colleges have stronger kind of entryways into nursing and psych nursing, or, that pathway is, those agreements are put in place so that we can help students find their way as they start in the community college and then figure out where they want to go. Right, Clarissa?
Yeah, yeah. And just a follow-up question, like nursing has become so expensive that it has become incredibly hard to get that equity lens within a nursing degree where we would be streamlining somebody into like what I do as a psychiatric mental health nurse practitioner. Like, it's already so expensive, and the community college is such a good option for people with an equity lens for nursing, but those programs are so much smaller. And I went to OHSU down here and it was incredibly expensive. I cannot imagine how, and there's not a lot of grants or scholarships that I think fund the entirety of your nursing degree. So I think you guys are right on with like community colleges are where it's at, especially with that equity lens. But we have to, think about that, like what's the expense of continuing on to get that bridge so that then they can get a BSN, because that's where the majority of psych nurses are working in hospitals, and they have to have a BSN in most hospitals nowadays. And then to go on to be what I'm providing is even, is I think I'm seeing a lot of nodding. You guys get what I'm saying?
Oh, yeah. Yeah, for sure. And just making sure those pathways are clear so that students know how to get where they're going. Yeah, agreed. Thanks, Clarissa. Anything else that's coming up for people as we're thinking about community colleges and the pathway to behavioral health through there? Okay. Well, here's the good news is we only have one more. Oh, Shara, I'm taking it back. We're not going there yet. What do you want to add?
Just I've had some conversations recently with like folks on our people and culture committee and folks who are really dedicated to like diversity, equity, inclusion in our organization. And there's a learning and a development gap between folks who've maybe like come into this profession and gone through a master's program where they're getting the sort of like the social justice foundation and really understanding the intersectionality of oppression and how our different systems like play into and create illness, and also understand how to be culturally responsive and what cultural humility means, right? And like most of those things are deeply embedded in like behavioral health programs. I have folks who come into the field through AAs or like through community college or through lived experience who don't ever have that exposure, don't ever have that like foundation piece. And then it kind of falls to our organization to get them up to a speed where they're really understanding what cultural responsiveness, cultural humility is and why it's so critical in the behavioral health arena. And so I just want to like highlight that again. Maybe I don't know where it lives, but like it's an ongoing challenge for us. And that piece of education is so critical, whether you're a peer, a recovery mentor, or you're a psychiatric mental health nurse practitioner, right? Like we all kind of have to have that, but not all of us get that depending on how we enter the field or, what program we've walked through.
Yeah. Yeah, I appreciate you lifting that up because different programs have different requirements and different areas of focus that they bring into their area of learning. And so that's important for us just to think about. And I imagine that's got to land in one of our action plans, Shara. So we'll make a note to go back through and see where that is. And if it's not, make sure that it's added to how we're thinking about educating the behavioral health workforce, that everybody should have sort of that baseline of the context of the culture that we live in. And that equity lens is important. So thank you. Clarissa.
Sorry, just one more question.
Yeah,
I'm
no, you're
wondering
good.
with the lived experience portion, I love that idea. How would that translate into like a nursing degree? Did you guys have any conversation around that? Because like I went into my BSN program having worked with incarcerated and at-risk teenage girls in a residential treatment program. I would have loved to have gotten some credit, but I'm not sure how that would have translated because there are such specific I can't remember, I think it's called OCNI, and there's like with OHSU there were very specific things that we had to hit as far as like being competent nurses. So I'm wondering if there was any conversation around how lived experience, how that goal would translate into the medical side of behavioral health.
I think that's a great question. Again, Claire, so we didn't get down into the different professions. And so you'll notice in the action plan, there's a lot of mention of credit for prior learning. And that's where students can bring in their work experience to the community college setting or whatever educational setting they go in to say, I've done these things and how does that equate to what I need to do when I'm here at your institution? So that's where I think we're lifting up the work experience or the lived experience that you were talking about, Clarissa. But I'll open it up, Monica. I don't know if you have other thoughts specifically, or Alice for the community college space.
Go ahead, Monica.
I was just going to say, I think the credit for prior learning is still a bit of a gray area because it's not consistent across institutions and it's not consistent across programs. And so we can't say at all institutions, this kind of activity equals this class or this number of credits or, and that's an ongoing conversation that at least myself with other community colleges, we continue to have that conversation, like how can we make this happen and how can we make it equitable across institutions? But it's not done yet. It's not clearly happening yet, but it's an ongoing conversation that we have. Yeah, Alice, I don't know if you had something.
You said it. I think where we are now and where we need to get to in terms of recognition of prior learning and work experience is quite a ways. But I think actually, and it gets to a lot of the issues we're talking about with like institutional specificity. And there's a bachelor's degree in human services that Portland State offers. And credit for prior learning is one of the features of this that's been sort of advertised as like increasing access. And it is very hard to figure out what counts for what in that sphere. And it's controversial, but I think that's part of the conversation that we could be part of changing. So, and it will help nursing, but also all these other educational fields.
Thanks, Alice. Rachel.
Is there time for me to add one more thing? Because I know you have a whole.
We're good.
Okay, good. So the only thing I'll add in, maybe it'll make sense, but so nursing had this very intense, heated debate for years in the legislature, and it was, should community colleges be able to do RN to BSN programs? And then who regulates it? And you had universities against community colleges, and it went on for a while. Well, the good news is, in my opinion, it passed. Community colleges can now offer RN to BSN. Going back to, we don't do post RN licensure regulatory stuff. So we don't do that. The HEC does that. And so they are in the process, and those programs I think there's 2 or 3 that are about to like be online. And it will be interesting to see how, there was this debate, does it impact the workforce because they're already RNs, right, with their associates? But there are many reasons why institutions, organizations want that RN to have their BSN. And I don't know if there's anything like that in the behavioral health world, but I do know it will probably lead to some maybe more maybe nurses that lean into psych work care. I don't know. It'll be interesting to look back. But I just think it's interesting to know how many years there was that debate, and now that it's passed, and it's a couple of years, and now it's going to finally be instituted. So hopefully that fit into to potentials and how long a fight can go when we try to upset the status quo.
Excellent. Clarissa.
I just wanted to add, I think there's so much room for growth in promoting psych nursing and psych NPs within the behavioral health umbrella. And like I said, psych nursing, when you are in a program, it's not as like shiny or sexy as like ICU. And so there's so much room within your work plan to include psych nursing and psych pathways, psychiatric and just nursing, and on the way to what I'm doing. I think there's so much room to elevate that. So I really appreciate the work you guys are doing, and hope that that conversation is happening, including all of those nursing programs, because there's so much work to be done to get people interested in psych nursing and psych NP, as one of the pathways. So
yeah. Thanks for lifting that up, Clarissa. I appreciate it. And I appreciate all the comments and feedback around this action plan, because like we are saying, that the community college space is such an important one for us to be thinking about for all the behavioral health degrees. So thank you, everybody. As I was saying, this is the good part. We only have one more action plan, and we're going to move through this, and then I'm going to give you back your day. So our last one is around expanding degree pathways and completion. So the final plan focuses on degree pathways, strengthening alignment from high school through graduate school, and improving completion and transfer for students entering the behavioral health career. So the whole pipeline is what we're thinking about. And here's the context on the next slide for the recommendations. No, I'm ahead of myself again. Can you go back one, Chad? Thanks. So the purpose and the focus areas are really around the need for more behavioral health degree options, clear academic pathways, stronger transfer and articulation agreements, which we've just talked about, and better completion supports. So the plan really responds with pathway alignment, again, thinking about that pipeline from high school to career, the pilots, the multilingual resources, improved advising, and faculty and staff capacity building to make these happen. So now let's walk through the strategies. Thanks, Chad. So 4 main strategies. The first one is strengthening articulation, transfer, and continued credit for prior learning agreements. We want to make sure that we have those so students don't lose momentum as they move between institutions, which is easy to do. The second one is piloting inclusive high school to career pathways that include dual credit, trauma-informed curriculum, and mentorship. I'm just going to name the hard part in this one is that the high schools are struggling with funding as well. And so bringing in more career pathways in that setting, while there's lots of great ideas to make that happen, we need to figure out how to make that accessible because the high schools are struggling with how to add more. Supporting faculty and staff capacity is in here as well. And that's really, we want to ensure that programs can grow sustainably. So those are the big pieces. And if we can do these things, then they're going to lead to the outcomes in the next slide. So the outcomes and goals are really around creating clear, inclusive pathways into behavioral health degrees, making sure that we're improving credit mobilities. We talked about with credit for prior learning, helping more students, especially non-traditional and underrepresented students, complete their programs, and then aligning education pathways with real workforce needs. We are hearing that a lot right now, that we really want to see how what's happening out in the field is informing what we're teaching in the classrooms. And so that's something that needs to be paid attention to. An easy part of this plan is to focus on equity. And if the next slide provides equity opportunities. And if we can do these things, it's going to expand equity by embedding culturally responsive curriculum, co-designing pathways with community partners, and recognizing lived and work experience through credit for prior learning. It also addresses gaps faced by rural, multilingual, and first-gen students by improving advising and ensuring accessible resources. So the goal is really a behavioral health workforce that reflects Oregon's communities, and it's prepared to meet their unique needs, because we're not a one-size-fits-all kind of place. And so ideally, everything we've outlined would address that. So let's just name the barriers that we're dealing with in this last action plan. And you're going to recognize these again, because it's the same stuff that we keep bumping up against. Funding and staffing challenges are not going away. Fragmented data and inconsistent credit for prior learning practices are a problem. We just spent a whole chunk of time talking about that, and we're acknowledging that that is real. And then the ongoing issues around digital access and advising capacity. It's not standard across institutions, and that's an issue. So the deliverables fall into that 3 to 9 month range. And then, all of it is going to happen in the process that it happens, and that may change as we go. So I'm gonna ask us to stop share. Any thoughts? If you're still with me on the last action plan of our 7, y'all, we got through 7 action plans today. Any thoughts around this last one of the degree pathways? I mean, that's really, for all of us, it's thinking about that whole pipeline. So I think everybody can plug in somewhere there. Liz, what you got?
I'm curious, did you guys talk about like the internship at all? Because I feel like that's where a huge barrier lies, is there's not really flexibility. I've thought of like, I've heard so many people say if there was like I could do it in a longer period of time instead of doing it in that like 6 month period of time, like spreading out the hours, especially now with not being able to borrow as much in student loans, people are definitely going to have to work while they're doing that, and it's pretty impossible to work and do an internship. So did you guys talk about that at all?
Yeah, it's a great question, Liz. We did not get specifics into like how internships roll out. Different institutions do it different ways. And as we think about it, what the requirements for internships in community college spaces are different than internships that are required in four-year institutions, whether that's bachelor's or master's. And so there's not consistency there, I think, which is challenging. We did meet with Amy briefly, Amy Baker, to just talk about, is there a way to make internships more cohesive or have more consistency across the board? And it's challenging for sure. I think what I could say is just in our action plans, we definitely identify internships need to be something that is expressly discussed. How do we make them not even just doable, but like affordable to do? It's like you were saying, you're not getting, for most of us, we're not getting paid while we're in our internships. And so that becomes a whole step away from our education process, and that gets challenging. So the short answer is I have no answers, but I think everybody in our subcommittee acknowledged that that is something that keeps coming up and that we need to help institutions figure out.
Yeah, thank you.
Yeah. I wish I had something better to say, honestly.
No, I know it's a complicated thing.
It is.
I wish there was more ease in it, but it's complicated. I appreciate it.
Well, and I appreciate that Summer's got their hand up, because Summer, you're going to tell us how to fix this whole thing, right?
No. But I did want to just, it's interesting that I think most of us had unpaid internships. However, based on the labor laws now, I think almost all behavioral health providers are paying interns, and you kind of have to pay interns at this point, at least mental health interns, master's level mental health interns, or you will never get. I mean, we end up having to pay them quite a bit for their internships. And I'm not sure how many are still free for master's level programs.
We aren't able to pay our master's level interns. Sometimes for our bachelor's level interns, they can also work and we can give them credit for that work experience. And so basically pay them for their intern hours, but masters are still unpaid with us. So
I
unfortunately.
was gonna say what you just said, I think would be like a perfect pathway to resolving that is people being able to count the stuff that they're doing in their work towards their internship too, and just make sure that there's someone supervising. Like there's MSWs people who are like doing internships and doing less than I'm doing, but my stuff doesn't count towards it. So I think like that would be a way that it doesn't cost companies money, but it also allows for people to still make a living doing it.
Can I jump in here? Because I think as I was directing a BSW program, and there's a lot, like there are so many equity issues around unpaid internships, but it also created there were some weird incentive structures where students were getting placements only where they could get paid, and they were not good placements. And I'm not talking about anybody in this room, but I'm talking about a lot of like some for-profit organizations. And so I think having a systemic, like some kind of systematic way of supporting internships to create like robust experiences that are also making it affordable. And I think also like institutions are doing a better job of saying you can do this over a period of 4 or 5 quarters. There's no requirement that all the hours in social work, for example, happen in a particular window of time. I don't know about some of the other fields, but I think that's also something that we could change.
Yeah. Thanks for sharing that. Shara, you want to jump in?
Just to provide another example of like what organizations are doing currently when it comes to paid internships. It works for us when we have like a bachelor's level person who's enrolled in a master's level program and they're an employee. And now we can like build their internship into their hours, into their time. They're already getting paid and it's really budget neutral for us and it works for retention and grow your own. It's the applicants who are not already connected to my organization who reach out and say, hey, I'm looking for an internship placement. Now, I don't have that in my budget anywhere, right? We don't get money to support interns that aren't employees. And so I think that that's the missing piece because if I don't have an open position you can step into, I can't pay you because, right? So even though I want to and think you should get paid, that money's not coming from anywhere for me. So I think that's a gap for us.
And I think that's a great example, Shira, of just the complexity of this. Like some organizations have funds for paying interns, some organizations do not. Some universities do not let their students get paid for internships, period. Some other ones will support their students primarily and only going to internships that are paid. So it's such a kind of Wild West landscape for internships. That's one of the things that we're hoping with the learning and education and training pathways that we clarify some of these things so that there's some more consistency in there. Rachel.
So I don't know 100% what you all are talking about, wasn't on the subcommittee and in a different world, but I will say we created, so when I was in the legislature, I created it and now I regulate it, a nurse intern license. And so while they're in nursing school, they work as an intern and they get paid. They're not getting, clinical hours. They're doing that with their school, so it's separate. And we couldn't accrue both. And I think you just mentioned that there were some rules, and so it was one or the other, and they really needed like income and money. And they're kind of like CNA plus, like they do a little bit more. And then one of the hospitals in Oregon, in Klamath, Sky Lakes, they were the first to set it up, and they're going to have the first kind of graduating nurse interns to then roll right into their nurse residency. And I just think that transition and support through all of that will see some benefits. We modeled it off of a couple other states that were doing it. So I know there's intern when you're in school and clinical hours, but then creating this was an opportunity to make money and gain skills.
Yeah, thanks for sharing that. I think there are lots of models for us to be looking at. And so hopefully as we pass these action plans to the governor and the legislature, that was something that will be, that people identified these, we need to talk more about this. That's what we're going for. So thank you everybody for sticking with us today to go through all of these gazillion action plans. It was pretty impressive. You all get all the points. Just to let you know, we've now wrapped up. The next meeting is scheduled for December 18th. And so if you haven't received a calendar invite for some reason, you can reach out to Chad. He's great. He'll make sure you have everything you need. And then the same thing as last time, you'll get all the materials about 48 hours before, so you can go through it and have some sense of what we're going to talk about before we come into the space together. So the next meeting, we're going to do the same thing. We're going to review action plans before we advance them to the governor. But we are getting there, my friends. We are so close. So thank you for joining today and helping us figure all of this out. Like, it takes a village. So thank you all.
Thank you.